I'd like to welcome everybody to today's presentation covering the NBCC Code of Ethics 2023. This is part 1 of 8. And over the next 3 Wednesdays, I will be doing the first 3 hours. And then the following Saturday, I have a 5-hour intensive for those of you who need a whole bunch of live ethics CEUs. I'm your host, Dr. Dawn-Elise Snipes, and we're going to get started. We're really just going to go through the NBCC 2023 Code of Ethics point by point and talk about how it applies to us and not only our behavior, but also how it applies in terms of, for example, beneficence, monitoring our organization's behavior and making sure that they're behaving ethically as well. The NBCC core values and beliefs. With respect to all clients and work, counselors should seek to be as mindful of their humanity as they fulfill their counseling duties. We need to recognize we're all human. We all have good days. We all have bad days. We need to be open to hearing different opinions. We need to be tolerant and patient of alternate opinions. We really need to demonstrate healthy boundaries where I can say, these are my beliefs and they're what I hold. They're different from yours. Doesn't mean I'm right and you're wrong. It just means we have different beliefs about this issue. And we can agree to respect one another's thoughts, feelings, values, wants, and needs. It's important in the agencies that you work in that you also pay attention to make sure that any programs that are being created also respect the client's humanity. It doesn't make them feel like a number. It doesn't treat them like a assembly line. Every person that presents for services is different. We can't take 15 people and expect to have all of the exact same treatment needs and put them all through the exact same treatment program and expect to have good outcomes for every one of them. It's important to recognize the individualized nature. Counselors will be civil in their actions and words, avoiding arrogance, assumptions, and hubris. This includes, I know we don't like to hear that there's this bridge, if you will, between our private and our public life, but this also includes on social media. If you are getting on social media and posting your opinions, all right, but we need to make sure to do those civilly, without arrogance, and ideally, not trying to keep our social media profiles where we're sharing all of our personal thoughts, trying to keep that segregated from our professional, forward-looking face. And I know that feels to a lot of us disingenuous, but there's so much vitriol out there that it's really important to recognize that something that you say may be misinterpreted or may be taken away in a way that you didn't intend. And so we do need to be civil, both in person and on social media. We need to be civil with our colleagues. Not everyone's going to do everything that you like all the time. And recognizing and modeling assertiveness and, again, appropriate boundaries is essential. Recognizing if you think something is just radically wrong, okay, let's take a look at it before we step in and go and say, you're doing it wrong. We need to do it this way. That's kind of arrogant. It's paternalistic, especially when we are doing it with people that we serve. It's very arrogant for me to think that I know what's going to be the best treatment for Jim Bob the moment he walks in. I'm going to have some ideas about what I think might be the best, but Jim Bob's lived in his own skin for 44 years or however long. And he is also an expert on himself, his perception of the disorder, his cultural needs, etc. Counselors listen to others with intention and respond with respect. So we're listening to hear. We're not listening just to let them get it out so we can say what we want to say. We need to listen to hear what they're saying, what they're trying to communicate. But we also need to listen, in my opinion, to their behaviors. Not everybody can put words to feelings or to reactions or to memories. And sometimes people react from a place of trauma, from a place of fear that's communicating exactly that. And even if they can't say, I'm afraid right now, or I'm really angry right now because I feel like you're threatening me in some way, they may not be able to say that, but we need to listen to their behaviors and help them examine those behaviors and put words to them. When engaged in challenging dialogues, counselors do so to seek answers, not confrontations or harm. Whether it's about religion or politics and yes, that does come up in counseling, because sometimes people come in and they're like, I don't feel like my family gets me, or I want to make this change and I don't know if my family's going to be supportive, or whatever. Or whether it has to do with other life decisions that they may be getting ready to make. We want to engage in the dialogue and help the person explore it, problem solve, and find answers. When I worked in community residential treatment, one of the frequent issues that would come up is people would meet in treatment and they would go through 30, 45 days together. It was a short program, and they would decide that, they were cured. They were in full recovery now, and they were going to move in together. And that's one of the absolute worst things that people can do, is to go from being in a 24-hour structured situation to moving in with somebody who was also in that same 24-hour structured situation, into moving into a situation with no structure. So do I hold the fervent belief that that's a really bad idea? Yes, I do. However, it's not for me to be paternalistic or arrogant or confront my clients when they say they want to do that. I say, let's talk about it. Let's see if you've really weighed this out, and let's develop an action plan for you. Depending on the client, I might share my opinion in a very civil way, just letting them know, I don't think this is a good idea. However, you're a grown up and you're going to do what you want to do. So let's talk about how to minimize harm or any potential for harm. Counselors strive to be sensitive to differences in attitudes and culture. Counselors always seek to minimize undue harm and take particular care of those who are vulnerable or in anguish. When you have people who are in crisis, they feel vulnerable. When you have people who have been dealing with adverse childhood experiences or trauma for years, even though they may have figured out how to get through life on a day-to-day basis, putting one foot in front of the other, they still feel very vulnerable. And we need to pay attention to people's capacities and that's not meant to be condescending in any way, but we know when people are under stress, when they're in anguish, when they feel really insecure, vulnerable, that triggers their fight or flight response. When we're in fight or flight, we're not using those higher order thinking, wise mind skills, and we're not able to as easily problem solve. We don't have the same memory capacity. When people are in crisis or in anguish or feeling afraid, they are going to have a difficult time remembering things. They are going to have a difficult time processing things because their brain is just, they've got this loud voice in there going, fight or flee, fight or flee, fight or flee. And you're trying to talk over that. We need to take steps to do as much as we can to help them feel safe and empowered. And, sometimes, like in a grief situation, you're not going to be able to change anything right then. They're going to have to tolerate that sense of vulnerability, that sense of anguish. And we need to provide them adequate resources. Maybe Jim Bob last week was doing fine, and I'd give him homework assignments and tell him he needed to do these 2 or 3 things, follow up these referrals, blah, blah, blah. No problem. Well, this week he comes in and his mother just died, and he is just distraught because it was, his mother just died. Me expecting to treat him the same way, to give him a bunch of referrals and give him homework and everything, that's, ignorant at best and callous at least. He's not going to be able to do the same things last week and focus on the same things last week as he is this week because his neurological system has actually changed its focus. Counselors strive to enhance the social and mental well-being of their clients while supporting the overall physical health of each client. And there are a couple places in here where I've bolded and italicized things because they're kind of my soapbox issues. If you've watched my videos, you're aware of my belief that we cannot help a person reach maximal gains if we are not also attending to their physical health, if we're not also helping them understand how sleep deprivation, poor nutrition, high stress, chronic pain impacts their nervous system and their ability to recover, and strategies to address those things to reduce the hyperactivation of that stress response and help their body heal. We need to help them understand that chronic stress, chronic trauma can cause physiological problems that may need to be addressed while the body heals, like hypothyroid or gonadal hormone imbalances, or even sometimes nutritional deficits because they're so stressed, even if they're eating a good diet, it's just going right through them and not getting absorbed. Counselors must engage in self-care and self-reflection. I mean, that's kind of a no-brainer there. We're asking our clients to do it on a regular basis. We need to pay attention to self-care and self-reflection. We need to be able to ask ourselves, am I 100% today? Or am I struggling? And if I'm struggling, what do I need to do to provide myself supports so I can provide ethical treatment to my clients? We need to provide self-reflection on whether we are treating clients ethically. Are we developing romantic feelings for them? Are we keeping them on as clients longer than we really need to because they show up every week and they pay their bill? Are we, figuring out those ethical questions that we're going to talk about in great detail over the next few weeks? Access and equity are essential to the profession of counseling and fundamentally important for the success of any society. If people have mental health issues, if people have experienced trauma, everybody experiences trauma. Let's face it, some people don't have the skills and tools and resources to deal with it, and that's not okay. People need to have access to mental health as well as physical health resources that are of the same quality as someone else. It's up to us as clinicians, if we see that there is a gap in services, if we see that there is a problem, we advocate to fill that gap to make sure that there is access and equity. Counseling services should be provided to achieve the best mental health outcomes. Yeah. Counselors provide services to all of those in need using available resources and advocating for the expansion of resources in underserved communities. This kind of restates what we just talked about, but we also need to recognize if I'm sitting in my office in a community behavioral health center in wherever, I may notice that there are gaps in services. Maybe we don't provide adequate services to adolescents or something, or infants. Okay. So I may address that there in order to make sure that the clinic is providing the resources needed by the person served. However, we also need to step back and say, okay, who are we missing? Who is not coming to services because of the stigma surrounding it, because they can't get there, because of the cost, because of our approach, because of who we represent? Going out into those underserved communities and trying to figure out, why are they underserved? What is it that they need, and how can we tailor services to better meet their needs? I know in rural areas, telemental health has been a huge help for a lot of people because they just couldn't drive an hour and a half in for counseling. And there are a lot of other things that we'll probably talk about in upcoming weeks. Counselors and candidates demonstrate their commitment to ethical behaviors by demonstrating and representing to their clients sensitivity to multicultural issues, avoiding discrimination, oppression, and/or any form of social injustice. So those are the core beliefs that are the umbrella or the overarching ideas that guided the formation of the 2023 NBCC Code of Ethics. Now, let's briefly review those 7 ethical principles that we all know and love so much, and the 4 pillars. Depending on your university or your professor, you may have learned about the 7 principles or the 4 pillars. They kind of overlap. Your 4 pillars are non-maleficence, autonomy, beneficence, and justice, okay? And then the other 3 kind of fill it out. But non-maleficence is often summarized as do no harm. This principle mandates taking preventative measures to protect patients from harm and ensuring that the benefit of treatment outweighs the risk. Well, there's a lot there. The benefit of treatment does recommending placement for somebody in residential care when they've got a family and they might lose their job or something. Do the benefits outweigh the risks? And you've got an ASAM worksheet that you can do for a lot of these things. But that's why we have some objective measures to help us determine what the appropriate placement level is for the person. But even so, the quote, most appropriate placement level may not be what is best for the person as a whole. And we need to take that into consideration. We need to protect them from harm. And that means not only, your suicidal and homicidal ideation screenings, but we also need to make sure that our environment is safe and they're protected from harm. There's adequate lighting in the parking lots. They feel safe in the waiting room. Harm can be emotional or physical. We want to make sure that when they walk in, they don't feel discriminated against or attacked. So there's a lot that can be done by forming focus groups that are populated by the person served to help you identify areas that could be worked on or improved to help them feel safer and help make sure that they're not exposed to physical or emotional harm. Autonomy means respecting the right of individuals to receive informed consent. Ooh, that's a big one that we're going to talk about next week. And make their own decisions regarding their own health care. Obviously, if they are adjudicated unable to make their own decisions, then we're working with their proxy. But in most cases, even when somebody is in extreme crisis, they are able to make cognizant decisions. And whether they want alternative treatments, if you make a recommendation for residential treatment at your facility or IOP at your facility, and they're like, no, I have an addiction to opioids, and instead I want to go over to the medication-assisted therapy clinic and get on buprenorphine. You may not agree with that, but that is an option that's open to them, that they have the right to choose. And part of informed consent means allowing them or providing them the knowledge of alternatives to your recommendation. This is what I recommend, but here are some other alternatives. Some people would prefer to use spiritual leaders in their community. Some people would prefer to use something like acupuncture, which has actually been shown to be an evidence-based practice for addiction, by the way. And we need to be open to that. Even if you haven't read the research and maybe you're not, or even if you have, maybe you're not completely convinced, okay, but it's still their right to choose. We need to respect their right to have referrals. Unfortunately, in a lot of systems, people come in for an assessment, especially clinics like behavioral health centers. People come in for an assessment, and it's assumed you are going to plug them into one of the services that you have available. And that's not necessarily the best placement for them. Maybe your competitor over here has a program that actually better meets their needs. And it's really hard, but that's where we look at our organizations and we say, does our organization support us making a referral to this other treatment facility if we believe and can document that they have a better option, a better treatment course for this particular individual. And they have the right to refuse care. Some people come in and you can see that they're really struggling, but maybe they were made to come in, they're involuntary, and they have the right to refuse care. When we treat them with humanity, when we treat them kindly, when we listen with intent to hear and understand, when we listen with respect, we provide an environment that empowers the individual. A lot of people come into counseling and they're like, okay, I'm going to go in and I'm going to have to bare my soul and feel vulnerable, and I'm not too sure about that. What we want to do is help people feel empowered to contribute to their treatment, to make decisions, and to understand that, okay, you have the right to refuse care. Even if they're court ordered, and I know some of you are going, but my people, the judge said, well, yeah, but they still have the right to refuse your care. It may mean they have to go back to jail. And I worked in probation and parole, doing the mental health side for a long time. And that was a discussion I would sometimes have with the people that I was assessing. I'm like, okay, now, these are my recommendations, and this is what the judge says you have to do. Now, you still have the right to refuse care, but if you do, that's in violation of your probation orders, and it means you're going back to jail. Full informed consent. Beneficence involves promoting good and preventing harm. Beneficence is something, again, in my opinion, that we as clinicians don't do enough of. And partly it's because we're so freaking tired at the end of the day if you've got to do 30 billables every week. So don't get me wrong. I'm been there, done that. I am not criticizing. However, through beneficence, we can look at ways to modify our programs to be more efficient and promote more good. We know that prevention, an ounce of prevention is worth a pound of cure, whatever. And prevention services, every dollar that we spend on prevention services saves about $8 for treatment. So it's a big difference. What would happen if we went into those communities served and promoted health and wellness and provided intervention level groups to people so they were getting the skills and tools they needed before they got to the point of crisis? Who knows? Beneficence can also mean advocating with local community mental health centers to write grants to fill gaps in services, or to go to your local, or not local, your state Department of Mental Health and Substance Abuse Services and sit down with somebody up there and say, we've got these gaps and we need to fill them. A lot of times, especially at the state level, they don't know what your needs are on an individual community level. Now, they aren't probably going to write you a check right there, but they may give you people to talk to that can help you develop the resources you need. Grassroots coalitions are also huge and can take a lot of time, or can be organized as such where it's, you meet for an hour once every other week or something and develop plans. It's a slow process. But what we're trying to do is improve services and improve the communities that we serve to prevent problems. Justice means ensuring fairness and equality in the distribution of resources and treatment. When I worked in community behavioral health, it was we had a residential addiction treatment program, one of the programs that I supervised, and the state priorities, we were largely state funded. The state priorities put people who used IV drugs, people who were pregnant, people who were HIV positive, and there was one other category. Anybody who showed up who needed residential services, who met one of those four groups, was jumped ahead on the wait list. They got the very next bed that was available. Do I think that was 100% fair? I can argue both sides of it, but it is certainly something that caused me some consternation, because I would have people who had diligently been on the wait list and calling in every week to see if there was a bed, and I thought they had a bed, and then all of a sudden, nope, it went to somebody else. I didn't have any control over that. That was a state mandate in order to get state funds. Did I articulate my displeasure with it to my boss? Yes. Did it do any good? Absolutely not. And then the quality of treatment. Justice means ensuring equal treatment. If somebody is going to a community behavioral health center or even receiving services in a jail or a prison, they should be receiving the same quality of services that someone is receiving at a private healthcare facility. And I recognize that the reality of that is not so. I'm not sure if I'm saying that right. I recognize that private facilities can pay a whole lot more. So they tend to recruit the, quote, best and brightest. And the people who are working in community behavioral health and jails and prisons are willing to accept a lower salary. Now, sometimes that's because our heart is there. We want to help people who need help and help people who have been disenfranchised. So there are a lot of very talented people working in community behavioral health and jails and prisons. But there are also some other people who may be so burned out and so overworked that they are having trouble providing the same quality of care. And burnout is a huge thing wherever you work. Veracity means providing accurate information to patients even when the truth may be difficult for them to hear to enable informed decision making. If you're working with a child and you're working with little Bobby, and little Bobby's making progress, but it becomes abundantly clear to you that half or more of little Bobby's problems are because he feels unsafe and powerless in his home because his parents fight all the time and because he has never formed a secure attachment. And you recognize that caregivers have uncontrolled mental health or substance abuse issues that are contributing to this, but they keep saying, it's all Bobby. Fix Bobby and everything will be good. But you recognize, hey, I can't fix Bobby unless we fix this system, this environment that Bobby's living in. Mandatory reporting is another one where we need to provide accurate information. It is in most cases, now every once in a while, you got to do it without the patient's knowledge. I can't say I've ever had one of those situations, but you need to weigh the safety of the potential vulnerable individual. For example, if you're seeing a patient who you believe you have good information that this patient is abusing their child, probably not safe to say, hey, I'm going to call DCFS on you and make a report because I think you're abusing your child, and then have them walk out and go home. That's probably not a good idea. If, however, you've got to make a report, maybe there's domestic violence in the home and the children are exposed to it, that's an adverse childhood experience. It's a mandatory report in most states, I think all states. I found that it is typically works best, and I believe it's most ethical if you let the person know ahead of time, this is a mandatory report. Now, we've got a couple ways to do this. Either you can call and make the report in the office, and you can talk to them yourself, and then you hear them make the report, you get the name of the person they made the report to, so you're empowering them to take a step. Or I can make the call while you're in the office so you can hear what I have to say. Or I can make the call after you leave. But the call's got to be made. And that can be really, that is really anxiety provoking for most clinicians because we don't want to alienate the people we work with. We don't want them to feel like we're taking their power. But sometimes we do have to make those reports. Fidelity refers to loyalty and faithfulness to your commitments and responsibilities. If you say you're going to do it, then do it. If you make your promises, then keep them. And I will add to that, if you schedule an appointment for 7 a.m. or 9 a.m., see the patient at the appointed time. Don't see them 30, 40 minutes later, an hour later. When we double book and we run late, that is disrespectful to our clients. And it's not upholding our commitment because the commitment is, hey, I will see you at 9 a.m. And then they come in and they're sitting in the lobby for an hour and they're like, oh, what the heck? Yes, I know crises happen, but a one-off is very different than if every time you go, the clinician runs 20, 30, 40 minutes late. Accountability is the last one, and it emphasizes the responsibility of individuals to ensure transparency, maintain professional standards, and answer for their actions and decisions. We need to be accountable for quality of care. And sometimes if there's a sentinel event, for example, it's another one of those times it can be really anxiety provoking to report it and go, hey, I screwed up. I made a big mistake. Or there was this huge problem that I was involved in. It can be really anxiety provoking, especially in punitive environments, which again, the organization needs to adopt a non-punitive stance in order to get people to be honest, because we can't fix problems if we don't know they exist. We need to be accountable for our quality of care. If I'm burned out and I'm just barely showing up, I'm there and I'm kind of checked out while the person is talking, that's not quality of care. I need to be accountable. I need to be mindful and self-aware of my ability to provide quality services, and I need to be held accountable to my clients and my organization that I am providing those services. In ethical decision making, we have the ABCDEs: assessment of the problem and the impartial, generalizable, and justifiable options. Assessment of the benefits of each of those impartial, generalizable, and justifiable options. So impartial means, considering treatments other than maybe your clinic. But the benefits of the short and long-term options. Consequences of the short and long-term options. Every decision we make has benefits and consequences, whether it's financial consequences or time consequences or quality of treatment consequences. There's consequences. And we need to be able to objectively write those down, the benefits and the drawbacks of each of the options, so we can better decide on a course of action based on which of the ethical options will minimize conflicts between the client's and others' rights and the welfare and society's rights and interests. So we need to look at the big picture here. There's the client's rights. We need to recognize that, but we also need to recognize the bigger picture. It's not always just about the client. If the client has homicidal intentions and there's a imminent threat, we need to make sure that we are engaging the appropriate course of action, even though maybe the client doesn't want to go to crisis stabilization. It may be something that has to happen. Now, that's the outlier, but making the best course, making the best decision. Evaluate your outcomes. Once you make that decision and take that step, evaluate how it worked. And you may not be able to change that. Maybe it had a bad outcome and the client discharged from services. Okay. Hopefully we can provide them referrals to somebody else. But at the worst, you're going to be able to learn from it what to do better or differently next time. At best, you can still work with that client and say, okay, well, we zigged right to try to address this issue and it didn't work. So why don't we try zigging back left to see if that works any better? So you're kind of engaging in rapid cycle change. And if needed, seek consultation. A colleague. Ask them, in this situation, what would you do? All right, now to professional responsibility. We're finally into the Code of Ethics. Counselors shall perform only those professional services for which they are qualified by training, education, and supervised experience. EMDR. To the best of my knowledge, there is no state that currently regulates EMDR. There is a certification by the EMDR International Association or something, EMDRIA, that you can get that demonstrates that you have had training and experience, but it's not required to use EMDR. Now, I personally think that it is dangerous to use a technique for which you have not been trained or you've only read a book on it. You're working with people's lives. Everybody's going to make their own decision about what's ethical and what's not. I know there are online services right now where people can sign up and self-administer EMDR. So, there's a wide gamut of what is ethical, but it's important to consider. And honestly, considering if this goes badly, Are you going to be able to demonstrate to a court that you behaved in a manner that was consistent with other reasonable professionals? Are there a lot of other people out there providing EMDR services who are not EMDR certified? My understanding from around here and my colleagues around here is no. Most people who provide EMDR have actually gone that extra mile and gotten the certification. Therapy with children. Oh my gosh. I was trained for many years. I did graduate school. I did a 3-year internship after graduate school. I have a lot of training, but I was not trained to work with children. And children are not little adults. They think differently. They have different needs. They're in a completely different situation. And just randomly saying, hey, I can see kids too, without receiving training on actually providing services to children and supervised experience providing services to children, you're really on some very uneven or unsafe ground. Same thing is true with addictions and eating disorders. Yes, they occur. However, are you equipped to deal with them? Do you know what's causing them? Do you understand the mechanics behind what you need to help the person address in order to move toward recovery? Or are you just plugging and chugging because you've heard people say, well, there's these 12-step meetings and whatever? Or you think if you resolve their trauma, then spontaneously their addiction will remit. No, it's not going to. Hint. So again, if you're working with people who have treatment issues that are different than what you're used to or different than what you've been trained in, you need to seek supervision at the very least. I have not had a lot of people that I've worked with that were in the coming out process for LGBTQ. And I did have one client at the clinic in Nashville that I worked at. And I felt ill-prepared to help this young person navigate this monumental process for them to, start displaying their authentic selves to their friends and family and the world. So I sought consultation. It was in order to provide services. I'm not going to discharge and refer because that's often feels like a rejection to the client. I'm going to say, all right, I'm going to tell you this is not something that I have been extensively trained in. So you have options. If you want me to make a referral, I will. If you want to continue to see me, then I will seek supervision so I can best help you to navigate this process. And that's what we need to make sure that we are doing. Providing nutrition counseling is another one. Now, there was a recent change in Florida law, for example, that we can help people eat more nutritiously. We just cannot make any sort of nutritional prescriptions to treat any sort of disorder. So we're not going to give them a menu to help them address diabetes. We're not going to give them a menu for nutritional help for their depression, for example. What we're doing is providing nutritional information if we are qualified by training. And if we are not, then we seek supervision. Now, I know the text on this is small, but all 4 of these bullet points are related, so I wanted to keep them together. Counselors shall accurately represent their current professional qualifications and credentials in counseling or closely related disciplines and not use doctoral degrees from other disciplines. If you have a doctorate in theology or a doctorate in biology, awesome. Good for you. That was hard work. But you can't use it to say, I have a doctorate in counseling. You need to clearly identify if your PhD is for something other than counseling. You need to clearly identify that, like parenthetically put biology. Identified U.S. degrees must be from colleges and universities that were accredited at the time of graduation by one of the institutional accrediting organizations recognized by the Council for Higher Education Accreditation. And most states go further and say that your program had to be accredited by CACREP. But it's important to understand you can't just go to any college anywhere and have your degree recognized. It has to be an accredited college. And again, in most states, not only does the university or college have to be accredited, but the program itself has to be CACREP or CORE accredited. Counselors shall clearly distinguish honorary from earned degrees. Now, I don't know how you get an honorary degree, but yeah, if you get an honorary PhD, you need to put after it honorary. And counselors shall correct known misrepresentations or misperceptions of their qualifications. This is one I probably should have bolded because it's one that gets under my saddle. In most other countries, people who have a bachelor's degree in psychology can call themselves psychologists, okay? So in most other countries, and they have to have additional training, but they don't have to go to graduate school. And they can call themselves psychologists, no problem. In the United States, if you're going to call yourself a psychologist, unless your state has specifically said otherwise, if you're going to call yourself a psychologist, you must have a PhD from a program that was accredited by the American Psychological Association. You cannot say you're a psychologist just because you have a PhD in counseling, unless that PhD, again, is from a program that was accredited by the American Psychological Association. Too often, I see on LinkedIn people claiming to be psychologists. I'll see like PhD, LPC, and I'm like, okay, well, it's possible you got your LPC and then went back to school and graduated from a APA accredited program or something. I mean, there are a lot of possibilities, but did they? Did they actually go to a different program, or are they calling themselves like a psychologist with a PhD in counseling or counselor education or social work? So that's really important to recognize. And if somebody calls you a psychologist, it's important to correct them because you don't want to misrepresent yourself to them. And, it's fine. It's great. If you've got a PhD, more power to you because, been there, done that. I know it's hard work. However, it doesn't give you the right to use the title. In some states, you can get a master's from an APA accredited program and be a master's level psychologist. But again, it generally has to be an APA accredited program. The APA has that title locked down pretty tight in the US. Counselors shall seek professional assistance or withdraw from the practice of counseling if their mental or physical condition makes it so that they are unable to provide appropriate services. Burnout. This is one I hear so often, one I've seen so often. Hopefully you're working at an agency where if you start to feel burned out, there's the ability to do some job sharing or some, reworking of job duties so you can get a break for a little while, or transfer to a different department so you can get a break for a little while. Or you can take leave of absence or do something that allows you to rejuvenate before you get into the depths of burnout and despair. By the time you get to that point where you just can't do it anymore, you've been practicing unethically for quite a while. We need to recognize early stages of burnout where we start having apathy and negativity, pessimism, irritability with our clients frequently. Every once in a while, you're going to have one of those days where you're just in a mood. But recognizing when it starts becoming an issue and what you need to do to recover. Now, burnout, it's important to remember, you're a human being and you live in multiple different dimensions. And work may be the same and going well, but you've got all kinds of drama in your personal life that's causing you burnout. That's still burnout. It still means when you get to work, you may not be 100% for your clients. If you're experiencing symptoms of mental illness, you need to be aware. Are you able, if you are grieving, if you are clinically depressed, are you able to ethically and provide and are you able to provide quality services to the people that you are seeing on a day-to-day basis? If you've got family drama, maybe it's family drama that may not be burning you out, but it's keeping you distracted because you're worried about this, that, and the other while you're supposed to be focused on your patient. You may need to take that day off and get your stuff settled. Or if you're on medications that make it difficult to focus. Counselors shall obtain supervision or consultation with other qualified professionals when unsure about a client treatment or professional practice responsibilities. I think that's pretty straightforward. Counselors shall demonstrate multicultural counseling competence in practice. Most of us have to have a certain number of hours in multicultural awareness and counseling for every renewal cycle. So I do have several videos on that, but there are a lot of great resources from SAMHSA and National Institute of Mental Health that also can help you become more multiculturally aware based on the persons that you serve. If you are working with a American Indian or Native American population, the cultural needs of that group is going to be very specific and maybe even down to the particular tribe that you're working with. And so it'll be important to focus your attentions there. Counselors will not use counseling techniques or engage in any professional activities that discriminate against or show hostility toward individuals or groups based on gender, race, ethnicity, national origin, sex, sexual orientation, disability, religion, or any other legally prohibited basis. The takeaway I get from that is, of course, be human, be kind, recognize humanity, recognize that everybody deserves to feel safe and loved, and review your evidence-based practices for cultural sensitivity. Motivational interviewing, for example, has been adapted for multiple different cultures in order to make it more culturally responsive. Counselors shall not misuse their professional influence or meet their own needs at the expense of a client's welfare, including but not limited to the promotion of services or products. If you're in a counseling office and maybe you're a believer in aromatherapy and you have your own white label aromatherapy product line, okay, it's out there, but it's important not to have clients feel like they need to do this or put undue influence on them where they think, oh my gosh, I have to have this. We need to educate them. Same thing with books and mugs and whatever else you may be selling. Counselors shall not solicit testimonials from current clients or their families and friends. This gets violated constantly by treatment centers. And the way they go around it in many cases is they have the business developer or somebody else contact the client and say, hey, will you do a testimonial for our treatment facility? And yes, it's not a counselor doing it. However, it's a representative of the agency that provided the counseling. And in my estimation, that's unethical. That feels really icky to me because I feel like the client may feel pressured to give a positive review. I feel like the client may want to respect their own confidentiality, but feel like they can't because they've been asked to do this by an authority figure. So it makes me feel icky. You're going to have your own ethical judgment on it. Recognizing the possibility of future requests for services. Counselors shall not solicit testimonials from former clients within 5 years from the date of service termination. So even if somebody terminated services and, again, they had a great time, whatever, they think you're wonderful, well, great. But we're not supposed to solicit testimonials from them for at least 5 years. Counselors who become aware of another's mental health professional's unethical behavior shall first attempt to resolve issues through reasonable means, except when state regulations require immediate reporting. If the counselor is abusing the client or neglecting the client, or if the counselor is severely impaired, then it may be an immediate report. Otherwise, it's going to be important to either discuss it with that counselor or discuss it with that counselor's supervisor. There are different ways people go about it. Obviously, the best way is the most direct way, and that's go to the person. In the event that it cannot be resolved, counselors shall report the matter to all appropriate professional regulatory organizations and agencies. Whether you need to report it to the state board, whether you need to report it to DCFS, I can't see why you would, but thinking of who you need to make those immediate reports to. And generally, when you report to this, most state boards have a hotline or a form on their website for making an ethical complaint, an ethics complaint. Counselors shall discuss service termination with clients when there's a reasonable belief that the clients are no longer benefiting from or are unlikely to benefit anymore from future services. Don't keep people on your caseload if they've met maximum achievement, that they've done their best at this level of care at this time. You can discharge them, and then if they are ready to come back, then you can welcome them back. But don't keep clients on your caseload for years unless you have a really, really good, objective, demonstrable reason to do so. Counselors shall not abruptly terminate counseling services without good cause or significant justification, and in such cases shall discuss and provide appropriate referrals. Now, most of us are not going to decide to fire a client and just, okay, fine, I'm done with you, goodbye. We need to discuss with them if things are not working, if we're thinking that, you've no-showed 3 times, something. We need to talk with them about it and figure out, can we still work together and what needs to change? If we do end up having to terminate services, we need to provide referrals. If the client no-shows, in where I've worked, it's always been if they've no-showed twice in a row and we haven't heard from them at all, we need to reach out to them by phone. If we can't reach them by phone, we need to send them a certified letter that lets them know that we will be terminating them by XYZ date unless we've heard from them. And in that same letter, provide referrals. Counselors shall adhere to legal standards and requirements, including state licensure regulations. If you're not sure of what yours are, you can Google professional counselor and then the name of your state and rules and statutes. Rules change. Florida just had an immense amount of changes to their laws and rules, especially around involuntary commitment, that I think a lot of clinicians aren't aware of. So it's important to periodically review those things. So for example, if you pull up the Georgia Counseling Board rules, it tells you what the rules are. It also tells you about proposed rules that haven't passed yet. And then it links you to the laws. There are generally multiple areas. Kentucky does the same thing. And Kentucky's kind of like Florida. There's lots of different laws and rules to be aware of. Alabama, again, the same thing. There are codes, rules, statutes, and they even have the Wellness Program Act that you need to be aware of. The Florida Board of Clinical Social Work provides information for you about what Florida people need to do. And Florida statutes and administrative codes. In Florida, you need to be aware of Chapter 491, 456, Chapter 120. It's a pretty extensive list of things that you're responsible and going to be held accountable for, potentially legally and ethically, that you need to know. For example, and I know we're at that time. This is the last slide, so if you absolutely have to go, have a great day, and I'll see you next Wednesday. In Florida, for example, standards for intensive outpatient treatment. It gives you very specific standards for what you need to do, the services that need to be provided, and the maximum number of individuals that any therapist can have on a caseload, as well as what you need to do about hours of operation. So Florida is very, very specific in their laws and rules about what you need to do. So if you're in an IOP program, you are ethically and legally accountable for knowing what these things are and ensuring that your agency is upholding the laws and rules of your particular area. Counselors who make public statements inconsistent with this code or other professional counseling standards shall state that their opinions represent their personal views. They shall not make statements on behalf of NBCC or other organizations unless officially authorized to do so, and shall provide professional counseling presentations. Counselors providing professional counseling presentations shall ensure that the content is consistent with this code of ethics. So like we talked about today, I gave you a lot of examples, but I also owned that what was my perception or my interpretation or my feeling about those particular scenarios. And I recognize that you may differ and NBCC may differ. We are just intentionally going through these to help you understand the things that you can be held accountable for by NBCC and your state board. This is part 1 of the ethics series reviewing the 2023 NBCC Code of Ethics. Part 2 is on August 7th. Part 3 is August 14th. And then our 5-hour seminar, which is actually going to be a video-based interactive webinar. So it's not going to be just me talking at you, I hope, is going to be on August 17th, which is a Saturday. NBCC Code of Ethics is designed to provide an aspirational set of standards guided by the core values of the profession. We have laws, which are our minimum standards, and we have ethics, which are our aspirational standards. We want to be as close to those as we can, and reality often happens somewhere in between. Part 1 reviewed the counselor's professional responsibilities.